nasty.
My background in training includes things like treating people with brain injury, spinal cord injury, musculoskeletal injuries, shoulder injuries, and rehabbing these people back to health using physical therapy, occupational therapy, or speech therapy, or whatever they need in order to get them back to function. So if you have damage in your neck, it's very common that you can get referred pain, because if you have an inflammation and irritation of the nerve, that wherever that nerve travels, you can feel the pain.
Pain management. I'm sure a lot of you have heard that term, but you have no idea what it means. Well, today we have Dr. Karam Sial. Dr. Sial is Harvard trained and one of the best pain management doctors in Southern California. Dr. Sial is going to talk about what it means to be a pain management doctor and what the difference is between a regular MD and a pain management doctor. On top of that, he's going to really break down the different types of procedures and ways that he helps patients who are in pain recover from the pain. The procedures we're going to go over are epidurals, facet blocks, and endoscopic microdiscectomies. And these three different types of procedures, and also we even get into rhizotomies, which is a radiofrequency ablation. If you're interested in pain management at all, or if you want to hear about the different ways that you could potentially get help with your pain, or if you're a doctor, if you're an attorney, this is the episode for you. He brings models and explains and shows the details of how he does these procedures and how he can help any patient who's been injured. So tune in today. This is going to be a great episode for you to learn all about pain management. So, hey everyone, and welcome back to another episode of the Nasty Truth Podcast. Today we have Dr. Karam Sial. Dr. Sial is a pain management specialist who is a doctor in Southern California, and he is Harvard trained. I'm going to talk about a lot of the accommodations and certifications and accomplishments of Dr. Sial, so give me a minute here. I'm going to run through them. But Dr. Sial has certifications as a board-certified diplomat of the American Board of Physical Medicine and Rehabilitation. He has a certification with the subspecialty board certification in pain medicine through ABPMR, and he is also board certified American Board of Independent Medical Examiners. At this point, Dr. Sial is the CEO of a company called American Spine, which provides pain management doctors through Southern California to help patients who have been injured. He has also been published in many different publications that on discussions on pain management. He was trained at Beth Israel Deaconess Medical Center, which is a Harvard Medical School accredited institution, and he has awards such as the Vital's Top Compassionate Doctor Award. He was nominated as Vital's Top 10 Doctor Award. He has received a second place research award from Louis Leviat Memorial Lectureship. And he is affiliated with several hospitals in Southern California, including Inland Valley Medical Center and Orange County Global Medical Center. He is also part of professional memberships such as Diplomat of the American Board of Interventional Pain Physicians, American Society of Interventional Pain Physicians, Spine Intervention Society, American Academy of Pain Medicine, American Academy of Physical Medicine and Rehabilitation. He's done many presentations on pain management throughout California, and he has been licensed since 2005, correct?
That's correct.
Yeah, so as everyone can tell here, we have Dr. Sial, and he definitely knows what he's doing when it comes to pain management and being a doctor in regards to this field. So Dr. Sial, thank you so much for being here today.
You're welcome. Thanks for having me.
Did I miss anything, or is there anything else specific that we should highlight?
No, I think that you did a pretty good job.
Okay,
Yeah.
Awesome. Thank you so much for being here. So
Yeah.
today I wanted to have you on. I really want to talk about, what does it mean to be a pain management doctor? What's the difference between a pain management doctor and an MD? I want to get into what are some of the things that you do for patients? How do you treat them? Like, what's different than a normal MD that might prescribe Norcos or, hydrocodone? And what do you do different to really help patients and clients get back from when they've been injured? So I'm going to let you kind of start off and tell us, what does it mean to be a pain management doctor?
Sure. So as a pain management doctor, we come from two different backgrounds in training. So there's two different sort of residency programs that most pain doctors come from. One is the background of anesthesia, and the other is a background of physical medicine and rehabilitation. So just kind of going over what you had said earlier about my residency. And so I did mine in physical medicine rehabilitation. So my background in training includes things like treating people with brain injury, spinal cord injury, musculoskeletal injuries, shoulder injuries, knee injuries, and rehabbing these people back to health using physical therapy, occupational therapy, or speech therapy, or whatever they need in order to get them back to functioning. So that's the background. And then I did an interventional pain fellowship where we learned how to do different types of procedures, injection type procedures, in order to relieve pain using medication.
Okay.
So that's the background. So there's a lot of pain doctors who come from the anesthesia background, and so their background is more of putting people to sleep and waking them up in the operating room, and then they also do an interventional fellowship. It's similar interventional fellowship as we do to learn how to do all these different injections. So pain management doctors, basically our goal is to try to control and relieve pains to improve function.
Okay.
And we try to do that using the interventional guys would prefer to use an injection or a procedure to try to get them better for a longer period of time than using medication. As you mentioned, some of those opioid or different medications may only last 3 or 4 hours, and then the pain comes back.
Okay. And so you guys, can you explain how you differ from a normal MD? Is it just the certifications or the trainings that you take, or is it just specifically the type of, let's say, procedure that you might provide for the patient?
So going back to that training, so the way doctors are trained is essentially there's your medical school training, and medical school is 2 years of book work, just like college, where you're sitting in class with a professor who's teaching you, and you read books and you take tests. Then there's 2 more years where you're actually in hospitals and you rotate through a surgery field, and you rotate through the pediatric group, and you rotate through different sections of different types of doctors where you're actually at the hospital working with these doctors.
That's not the residency.
So that's just medical school, right?
Okay, that's still medical school, but you're still working in offices and you're learning.
And you're still working in hospitals, but you're working with other doctors and other specialties. So you might do some family practice, internal medicine, and surgery, and OBGYN, which is delivering babies. So you kind of do a little bit, and you work with all the different types of doctors. And once you finish your medical school, you decide you specialize. So you do your residency in just one field.
Okay.
And so some doctors will say, I want to be a primary care doctor, and I want to kind of treat the whole family. So they'll go and do their residency in family practice.
Okay.
And then they'll spend 3 to 4 years in a residency program where they're just training and seeing patients and working with family practice doctors, and basically training as a family practice doctor.
Are you required to do residency?
You are. I think in California, if you only finish 1 year of your residency, you could potentially get licensed and practice. But I would say 90% of the doctors out there finish their residencies, and then they go out and practice. So yeah.
How long is a typical residency?
So typical residencies are 3 to 5 years. Most of them are, I would say, 3 to 4 years. And then if you want to subspecialize even further, there's an extra year, we'll call it a fellowship, or sometimes 2 years. So you can do it in primary care, you can do it in radiology, you can do that in physical medicine and rehab, which is what I did. You can do it in anesthesia, and there's so many different fields where you do your residency and you sort of specialize. So the difference between my training and a family doctor is that I did my residency specifically in this physical rehab medicine.
Okay.
And then specialized even further to do a fellowship, which is that extra year. So I did 4 years of residency in physical medicine and rehabilitation.
Okay.
And I did that at Baylor College of Medicine in Houston. And then I did an extra year of training, which is the interventional spine fellowship training. That's where we learned to do all the needle injections.
Okay.
And that was the extra year after my residency training.
Got it. But your original schooling in the first couple of years was the same as any normal MD, and then really where you learn what you're going to do is where you specialize through your residency, or where you actually train under other doctors, correct?
Yes, that's correct. Yeah. So then I would finish my residency and my fellowship, and that's kind of how I specialized into that one field of spine care.
Got it. Did you always know that you wanted to do pain management and medicine, or did you have no idea? Did you maybe think you want to be like a surgeon or something like that when you were younger?
Yeah, I really didn't. I was kind of undecided, and I first came into it, and I've always been sort of athletic and tried to stay in shape. So I've always been kind of geared towards sports medicine, and sort of that kind of led me down this field of physical medicine rehabilitation, because we do a lot of musculoskeletal medicine and sports medicine, and treating people with knee injuries and ankle injuries and rehabbing them back so they can get back on the fields, and shoulder injuries and things like that. So that kind of led me down this route of this rehab medicine, physical rehab medicine, not drug rehab, but physical rehab. And so then that led me to, I started learning about these different spine injection procedures, which I really took interest in and ended up specializing in further.
Yeah, and then these spine, did you do a lot of these treatments when you were still training in your residency?
Yeah, so most of my residency with training, we rehabbed a lot of spinal cord injury patients, but these patients have a lot of them either partial or fully paralyzed, and so they're in wheelchairs, or some of them you can't even move their arms or their legs if it's a high cervical cord injury. But we're rehabbing these people, and they have to learn how to how to brush their teeth, or even how to get out from a bed to a wheelchair and transferring and doing all that. So there's a lot of spinal cord injury that we did, and then brain injury as well, and then we do a lot of electrodiagnostics where we actually test the nerves of the spine. And so that all kind of led me to this focus of the spine. And then during my interventional treatment, it was more focused on people who have not really permanent injuries, but just back and neck pain, and injury, more acute injuries that can be fixed.
And so when you were working with these, so one of my best friends is actually a quadriplegic. It was actually one of the first cases that I ever worked on. It's a very sad situation. And were you guys able to use different types of techniques to help people regain feeling where maybe other doctors did not have success?
Yeah, well, there's definitely, when you first have a spinal cord injury, you can heal in the first year.
Okay.
And some people gain strength, and it's, so for example, somebody with a C5 spinal cord injury probably would have difficulty moving their hand and their biceps. But over time that they may gain some strength, and actually through rehabilitation, now they're able to use their biceps, and then now maybe they can do their wrist extension, which is the level below that allows wrist extension in C6. And over time, with rehabilitation, people do improve. There are some newer treatments out nowadays that are kind of on the horizon that are very interesting, and we're learning more about that every year. And the stem cells and the other things that people are learning more about are very promising.
Okay, very interesting. Do you have the opportunity to work in American Spine now on some of these types of patients, like paralyzed and quadriplegics and those types of accidents?
We do occasionally. Most of the patients that we see have disc herniations and end up having more of a less acute problems, but occasionally we do see some with more permanent injuries.
Okay, and let's talk about American Spine. So you've had American Spine now since 2012, correct?
Yes.
Okay, and American Spine, this is your company, and what exactly is American Spine, and what do you guys do?
So American Spine is a company that essentially treats people who have back and spine injuries and neck pain, and so our goal is to try to get them back to work, or back to the way they were before they had their injury. So we specialize in the spine, and we specialize on doing interventional procedures to try to improve their function.
What does interventional mean exactly?
So interventional means you're actually kind of more like invasive. So interventional procedures from a medical standpoint is usually requires some type of invasive procedure. You might be sticking a catheter through a vein, or you might be interventional cardiologists, that's what they do when they're trying to open up a vessel. But the same thing, an interventional pain doctor may be using needles or injections, or different types of needles that can block pain signals to try to relieve pain. So, when I first did my residency in physical medicine and rehab, you're using a lot of physical therapy, occupational therapy, and this is more exercise based and range of motion and strengthening, and so that's not really invasive. It's more of a active and passive treatment. Whereas once if that doesn't work or they're still having issues, then we'll get into then we'll get a little more aggressive, more invasive, and the interventional aspect is basically performing injections and procedures to try to relieve the pain and get them back to function.
Okay, and invasive just means like inside of the body, or can you describe what that means exactly?
Yeah, it just kind of means like through the skin. Okay. So if you can do anything from outside the skin, sort of like, an electrical TENS unit that's placed on the skin and it stimulates the muscles through the skin, that would be, non-invasive. But once you start going through the skin with a needle, that's invasive.
Got it.
So
someone might call that type of treatment like a chiropractic adjustment or physical therapy would be a conservative care, correct?
Right. So that would be sort of non-invasive and conservative care.
Okay.
And then invasive or interventional would be the next step, where you're actually introducing either a needle or some type of device through the skin, trying to get it down to where the pathology or wherever the pain's coming from.
Got it. And how many doctors do you have working with you now in American Spine?
So there's 3 doctors right now. There's Dr. Essical, who also trained, and his background is in anesthesia, and he also he did his residency training at Beth Israel Deaconess Medical Center, Harvard Medical School, and also did his fellowship there, the same place I did it. He was a few years behind me, and so Dr. Essical and I handle we do all of the interventional procedures. And then my sister is actually a physician assistant, Saima, and she sees patients in some of our locations. She does some evaluations, consultations, and some follow-ups.
Okay.
Yeah.
And so, you've said that you've been doing these procedures for a long time. Do you have any idea approximately of how many procedures that you've done?
Oh, wow. I don't think I could keep count. There's, probably thousands. Yeah, thousands.
Thousands. I mean, so you definitely don't know what you're doing, right?
Right.
That's so, the different types of procedures that, off the top of my head that I can, name would be like epidurals, radiofrequency ablations, potentially facet blocks. What I kind of want to talk through today is, let's assume that a patient comes to you, right? They're in pain. We'll say, for the sake of this, because I do car accidents, we'll talk about car accidents, right? Somebody comes to you in pain, they have herniations, let's say 3 herniations in their cervical spine ranging from 2 millimeters to 3.5 millimeters, right? They come into your office, and what is the steps that you would take when you're evaluating them? Can you walk us through what an evaluation looks like and what you guys discuss and what goes down in that initial meeting?
Sure. So, when we first... when patients come to us, we'll do an initial evaluation. We would get some history. We start with the history, which is just them explaining to what happened and where it hurts and what kind of treatments have been done.
Yeah.
And that way we can kind of gauge where they're at with their care. And so they'll tell us all that. They'll describe where their pain is, and they'll kind of explain what kind of treatments they've been through. So if somebody has neck pain, for example, and lower back pain, then we'll want to know, is it radiating or is it just localized in the neck? Because it gives us kind of big information in terms of what's causing the pain.
Can you explain what radiating means?
Yeah, radiating pain is basically, the nerves come out of the neck and they travel down into the arm. Maybe we can just show here.
Yeah, absolutely, please.
Diagram. This is a little model, and you can see here, this is the spine. And so this is sort of the back of the neck. So this would sit inside me like this.
Okay.
So the back of the spine is here, and this is the front of the spine. And these things these are the spinous processes of the spine. And if you feel along your back and you feel those little ridges and those bumps, that's these spinous processes that you're feeling.
Got it. And those protect the spine basically.
Yeah.
They're like almost like dinosaurs.
Right. So the bones basically are protecting, and what's on the inside is the spinal cord.
Yeah.
And so the spinal cord is the yellow thing that's highly protected by all of these bones.
Yeah.
So we've been we were designed to protect that spinal cord.
Yeah.
And that's on the inside. And so it's protected with all of this bony work, but it also forms a structural component because these bones in the front, this is called a vertebral body, and in between each one there's a soft tissue structure that's like a shock absorber.
Yeah.
So it goes bone, shock absorber, bone, shock absorber, bone, and each of these shock absorbers is called a disc.
Yeah.
Okay, so you have all these bones with these shock absorbers, and these shock absorbers also are like a spacer. And by creating space, you have these little holes here.
Okay.
And the holes are where the nerve roots can come out. So you have at each...
So these yellow parts are nerve roots.
Yeah.
What they're showing. The nerve roots are attached to your spinal column and coming out of that, correct?
Exactly. So you have these... So your spine is connected... So here's where your brain would sit.
Yeah.
And your brain stem is basically connected to here, and then it becomes your cervical spine, which is your neck.
Yeah.
And the first 7 segments is called the cervical spine.
Yeah.
And and then that spinal cord comes down, and then it becomes the thoracic, which is the middle back from about T1 to T12 is how they're numbered, 12 in a row. And then there's the lumbar, which is L. The L stands for lumbar, and so you have 1, 2, 3, 4, 5 in the lumbar spine. So there's 7, 12, and 5, and that's your whole spine.
Is there a reason that they break it up into 3 sections? I was just wondering.
I think that's just kind of how they describe it. It's just there's no specific reason, but I think it just helps them describe the anatomy.
Got it.
So the neck, basically with the range of motion of the neck, the first 7 segments move a lot more than the middle segments.
Okay.
And then the lower segments move a lot more, just the way we're kind of curved.
Got it.
And so the cervical spine kind of curves one way, and then the thoracic spine curves the other way, and then the lower back curves sort of the same way as the cervical spine. And I think it's that curvature and the movement and range of motion that is the reason why they separated them.
Got it. And then you also mentioned, so those nerve endings, they go to different parts of your body, right? And like your neck specifically will go more to your arms and like this upper part, right?
Right.
And then the middle part might be attached to organs, correct? Or like different body parts along there. And then the lower part will be literally the nerve endings will go out to your like legs and lower part of your body.
Yeah, exactly. So the nerves that come out of these little holes here on the side up in the neck, they basically come out and they travel through your shoulder all the way down your arm to your fingers.
Yeah.
And so the first 5 or 6 up here will come together and they travel down into your arms. So if you have damage in your neck, it's very common that you can get referred pain because basically these nerves can cause, if you have an inflammation and irritation of the nerve, that wherever that nerve travels, you can feel the pain.
Yeah.
So
and you said referred pain. What is referred
pain?
mean?
So referred pain meaning like, so imagine if these nerves are like electrical wires, and they actually conduct electricity, and that's how the communication of a nerve response is basically an electrical impulse.
Okay.
And essentially what happens is you imagine like an electrical wire, right? And if you put a current on one side of the wire, and then you touch the middle of the wire, you'd still feel that current.
Okay.
And if you touch the very far end, you'd probably still feel the electrical current, right? Because it's traveling through that whole wire. So what happens is when there's irritation, inflammation in one part of the nerve, anywhere that nerve travels can be irritated, inflamed, and turned on. So referred pain meaning, like for example, the 5th one down, which is the C5, they number them and they call that the C5 nerve because cervical 5th one. So C5, we know it innervates the biceps and it supplies sensation to near the shoulder. So if somebody has a disc herniation at around the C5-6 level, and there is at the same time pain in the shoulder, a lot of people are thinking there's something wrong with the shoulder, but it's actually because that C5 nerve supplies sensation and also motor strength to the shoulder movement and the biceps that commonly people will complain of pain in their shoulder, and it's actually a C5 damaged nerve.
Got it. So it's your spine that's actually in pain. And if your spine, so I mean, like a lot of people don't understand that your spine is everything, right? If there's problems with your spine, it probably correlates to other injuries throughout your body.
Yeah.
Okay.
Right. Exactly.
Okay. And so so back to the example that I had. So we were talking about, I said there was a couple herniations, let's say assume from C2 to C4, right?
Right.
In that range. And so if they have that pain there, you know, after you talk to them about their history, what exactly do you do next? Or what do you do with, like, talk to them about?
So the next step is so once we get the history, we want to perform a thorough physical examination.
Okay.
And so during our exam, we understand, like, kind of the way what I was describing, the C5 nerve supplies sensation and strength to the biceps, right? So on my exam, if I find that the person has a weak biceps, strength testing, and that's and they have referred pain to the shoulder, it's kind of now it's all coming together, and it's a sort of textbook in terms of the complaints and the referral pain and now the physical exam. So if my exam findings also tell me that there may be a C5 injury based on weakness in biceps or sensory decreased sensation to light touch or pinprick in so that the shoulder area, then it tells me, well, my exam is also showing that there's maybe some nerve damage at C5. So, and then we do reflex testing, and there's certain reflexes that are tested or that travel through certain segments of the spine. So if somebody has a weak biceps or no reflex on that side, the biceps reflex, then again, that kind of leads us to believe there could be a C5 injury at the fifth cervical level of the cervical spine. So we have our history, then you have the physical exam, which also correlates, levels and tells you a lot about where the damage could be based on what part of the body is weak.
Can you walk us through literally what are these physical exams? Like, what do you physically do with the client, just so we can understand exactly what that is? Yeah,
sure. So for example, when I'm testing the biceps, I'll tell somebody to put their hands up like this. Okay. And then I'll tug on their arms.
Okay.
And I'm actually pulling on one side, and then I'm pulling on the other side, and people with weakness, it'll start to give.
Okay.
And we actually can grade that motor weakness. So this grade 0 through 5. 5 is full strength. 4 is just slightly less than full strength, or just less than full strength.
Yeah.
If they have 3 out of 5, that means it's they can raise it against gravity. But it's even weaker, but they can get it up above gravity. So when I say above gravity, meaning they can lift it up like this, because there's with gravity, they're still able to lift it against gravity, but it's much weaker than just slightly weak.
Okay.
And then the 2 out of 5, they can't even lift it against gravity. So they're if you have them set it down on the table and have them raise their hand up, they can't.
Okay.
So that's a 2, and then 1 is just kind of barely a flicker.
Got it.
Of movement. And 0, they just complete paralysis. So that's how we grade muscle strength.
Okay.
And then we also
I was going to say, I just want to comment on that. I remember I went to one of my chiropractors recently, and I was having an issue with one of my legs, and I couldn't use it properly. And then he adjusted me, and after he adjusted me, my strength came back to my leg.
Yeah.
And it's like you're talking about, right? It's like an electrical wire. If it's impinged at the source of the electricity,
right,
it affects the rest of the body. So just adjusting it allowed me to gain back strength, so that I was able to use my leg properly.
Exactly. Yeah. So if you can relieve the pain or inflammation or irritation on the nerve, then all of a sudden it can fire properly, and also with less pain. Some of the limitations is pain related.
Yeah. Okay. So let's talk about what other tests you do.
Okay. So we do the physical exam, and that includes a thorough neurological exam, and that's where we test the motor sensory testing, reflexes. And
what are some of the tests that you do for those?
So for the reflexes, I'm sure if you've ever been to a doctor and you've had them hit your knee with that little hammer, that's a reflex of your knee, which it tells us whether the L4 nerve is intact.
Okay.
So
And you say like numbers, like L4, like why is it number 4? Is that just relating to the fourth lumbar?
The fourth level in the lumbar spine, like I was saying
Okay.
earlier, there's 5 in the lumbar spine. The fourth one down, so there's 5 total. So 1 up from the very bottom one.
Got it. And do they like discern between the nerves on the left or the right side, lateral, bilateral, or anything like that?
Yeah. So of course, if you test the right knee, you'd be testing the right L4 reflex, and the left knee would be the left L4.
Okay.
Yeah, and so there's different reflexes in the arm that you can test. One is the biceps reflex, and there's another one called a brachioradialis reflex. So there's a triceps reflex, and so each one of those reflexes tests a different level of the spine. So so you're doing all of this stuff which correlates with specific levels of, based on your knowledge of knowing which nerves go to which parts of the body and which muscles. And when you test those reflexes, it tells you which nerves may be damaged. So when you do your physical exam, you get more information as to which nerves could be damaged.
Yeah.
And then you correlate that with what the C5, for example, like we said, causes referred pain to the shoulder. So if they come in with neck pain referred to the shoulder, and then you do your biceps reflex and it's absent on that side, now everything is pointing to a C5 injury. Okay. And then so then the next part is, okay, is there any imaging? And so a lot of times we'll order an MRI. And so an MRI is basically an X-ray type of test, but there's no radiation. It uses a magnet. Okay. Which is, I think it's good for people to know that. A lot of people are worried about the radiation. But anyhow, we will order these MRIs.
So you're saying there's a difference between like an X-ray and an MRI. So people should be more worried about X-rays per se because they are radiation.
Right.
But an MRI is not.
Exactly.
Okay, I didn't realize that difference until right now when you explained it. So that's good to know.
Yeah. There's no radiation from an MRI.
Okay, good. And so you go in there, you take this image. And so what is an MRI? Let's talk about that.
So an MRI is essentially it's a big magnet, and so you see them in imaging centers, and essentially it's this like a circular tunnel type structure, and it's got this very powerful magnet. In fact, you can't go and when you go into it, you have to take off any metal off your body because it's such a powerful magnet. It could just pull that metal and right off of your skin. So if somebody has a piercing or something, it could pull it right out.
Yeah.
So it's a powerful magnet, and basically the technology allows them to image the body and see soft tissue a lot more clear than for example an X-ray. Okay. So on an X-ray, it shoots a picture and you see great bony. That you can see the X-rays. If you've ever seen like a chest X-ray or anything, you can see the ribs. Yeah. You can see the spine, but you don't see any of the organs. You don't see anything between the bones. It's just kind of a black space. Yeah. Right. So that's because X-rays, the way they work is that they create an image based on the bone, whereas with MRIs you have images created based on the soft tissue. So if you want to look at, for example, one of these spacers here, in between the discs, in between the bones, which is called a disc, and you want to kind of assess whether, whether this disc is sticking out or whether it's damaged or if it has any signs of inflammation, an MRI will show you that.
Got it. And so in a normal X-ray, you'd only see those bones, which is the white part, but in an MRI, you can actually see the little discs in between. And those discs, those are ligaments, correct? It's the same material as a ligament.
Yeah, they're sort of made out of the same material as a ligament. You're right. Yeah, okay. Yeah. So there's different parts of this disc. The outside is more like rubbery, like kind of a tough ligament, and then the inside is more of a more of a kind of a gel material. They call them like there's proteoglycans and other things that have big words, but they basically describe the consistency of these discs, and the center of them is more of a gel and the outside is more of a hard rubbery material. And so with too much pressure, you can imagine like a jelly donut, right? If you smash a jelly donut, what would happen to the jelly? It would just squirt out, right?
It explodes out of it.
Yeah, so that's exactly kind of what happens to these discs. Is with too much pressure, that jelly in the center can actually explode out, And when it sticks out, it can push on one of these nerves.
Yeah.
And if it irritates the nerve, you're going to feel pain anywhere that nerve travels.
Got it.
So, for example, right here in the lower back, you can see here's a normal disc.
Yeah.
And then this one, which is the L4, because we said there's 5 in the lumbar spine.
Yeah.
So this would be numbered as the L5 disc.
Okay.
And the which is the bottom one.
Yeah.
And then the one above it is L4.
Yeah.
And then L3, L2, L1. And then it goes into the thoracic, which
The
would
12,
be
yeah.
T12 all the way to T1. And then there's C7 all the way to C1.
Okay.
But anyways, this would be L4. So this L4 disc, you can see this red area, and this is essentially where there's a disc protrusion.
Okay.
And from too much pressure, it's actually squirted out.
Okay.
And you can see that it's getting real close to that nerve root there.
So when you say squirting out, so that jelly-like material is just like sitting in that area.
Yeah.
It does that. So when that's not the actual disc itself that's like stretched out there, right? That means that the disc ripped, like that rubber-like material ripped, and then the jelly-like material that was in the middle is now leaking out into that area.
Right. So there's different types of discs that can bulge out, and some of them, that outer strong material is intact.
Okay.
And other ones, it rips open.
Yep.
And if it rips open, the stuff in the inside, which is highly inflammatory, it just really it's very irritating to the body. But when that stuff leaks out, it really causes a lot of inflammation around that nerve root and around this whole area.
Yeah.
Which inflammation leads to pain because those chemicals are super painful.
Got it. And so the fluid just almost sits there in that spot until it eventually recedes back into the body, right?
Yeah, so that disc, once it protrudes out, a lot of times it'll go back into place, especially if you're younger, or you're in better shape, or you're not, as obese or overweight. There's a tendency of these discs to heal, just like sort of when you cut your hand, what happens? You develop a scab, and then eventually it just heals itself,
Yeah.
So the body tends to heal itself, and so if you do the right treatments, this disc can go back into place.
Yeah.
And so that's what we're hoping, and so most patients don't want to jump to surgery, obviously. So when a patient comes and sees you, they're hoping that you tell them you're gonna be okay.
Yeah.
And so we try the least invasive care to get them better.
Yeah.
And so I kind of have like 3 buckets of care. And so the first bucket is conservative care.
Yeah.
And that includes things that we talked about, like chiropractic, physical therapy, acupuncture, massage, and maybe taking some anti-inflammatory medications and muscle relaxants, and give it time. And just let's see if it'll heal naturally.
Got it.
And that does a lot of times.
Okay.
So we'll say, all right, why don't you keep going to your chiropractor, or go to a chiropractor, or go to a physical therapist, and let's give you something to kind of help control the pain, and let's give it some time. Go home and rest, and do some exercises, and let's see if it goes away. And a lot of times it does. Those small disc herniations can recede and go back into place.
Okay.
Even if there's a small little tear in the disc, it can heal. So we want to get those MRIs early enough to diagnose that, so we don't miss it. But we also want to let it heal naturally if it's possible. But if it's been more than 4 to 6 weeks, and they're still having pain, then it's not healing. And usually they're in a lot of pain and they're suffering. It's affecting like their work. Now they can't do their job, and they're getting more frustrated. When people are in pain, they become very irritable.
Yeah.
It's just natural. That's the way we are.
Yeah.
And so now they're starting to yell at their family, and they don't have that, they're just become very irritable.
Yeah, I mean, it's tough. I mean, I've been in 4 car accidents myself, so like I'm well aware. I've like the worst I've had is like 3.8 millimeter bulge in my thoracic spine in my T6, and it's just like, it literally just feels like you have a metal object pushing in the middle of your spine all day long.
Yeah.
And like you said, you just find yourself more irritable. You're shorter with people.
Right.
It's frustrating. Even just standing like with proper posture, it's painful to actually do so.
Right.
And so you're right. It affects every aspect of your life, and it's a consistent thing. And most people learn to deal with it, right? And the way that I dealt with it is I just hunched over all the time.
Yeah.
And I just looked like I had really bad posture, but it was actually because I was in pain all the time.
Right.
And that's something that's hard to communicate to people. And so, there's a lot of frustrations involved for sure.
Yeah, and it starts affecting your mental, status as well, because
Yeah.
when now you can't work out and you can't exercise
Yeah.
or you can't do the things that you used to like to do.
Yeah, for sure.
And so now you're stuck at home and you're like, it really starts to wear on you.
Yeah.
So there's a whole mental side of it too, and the way that pain works is actually the nerves travel up to the brain, and it actually specifically splits into two directions when it hits the brain.
Yeah.
And it hits the pain sensing area, and then it hits the emotional area.
Yeah.
So it actually stimulates both of them. So when people are in pain, it's going to affect their emotions.
Yeah, 100%.
Yeah.
I think that's one thing that a lot of attorneys miss in cases. They don't get clients the proper psychological treatment that they need. I make it a
Right.
point on every case to offer it to my clients because there's PTSD involved with cases, right? There's emotional damage, like you said. They're just
Right.
frustrated all the time. And I think a lot of times people focus on the physical health, but they
Sure.
forget that there's a huge emotional aspect that goes along with being injured for that long.
Yeah.
And people don't address it. And I think
Right.
that's something, if any attorney out there is listening, like there are doctors out there that will work with you to help. And if not, help them get it through insurance, but make sure you address not just the physical pain, but the emotional and mental anguish that needs to be addressed by a doctor and not just
Sure.
in a demand letter or whatever it is you're trying to say to a jury. It needs to be addressed by a professional that can help them recover from that process.
Yeah, absolutely. I mean, a lot of times we'll make referrals to psychologists, and a lot of people have difficulty after, for example, after an accident.
Yeah.
When they go by that same intersection, they get severe anxiety.
Yeah, I have many clients that have been in they were life-altering cases where they've had major spine surgeries, like disc replacement, stuff that's going to change their life forever.
Right.
And just driving on the freeway for them,
Sure.
many times they will, I've had one friend, she got hit by a truck, right? And so every time she's on the freeway next to a truck, she starts having a panic attack. She has to exit off the freeway. She sometimes cries. She has to call her husband. It takes her about 10, 15 minutes. She composes herself, and then she gets back on the road. Imagine
Yeah.
you're dealing with this for the rest of your life, or even for the next
Yeah.
couple of years, just going through that traumatic scenario. And a lot of times these accidents are not the fault of the driver, right? They just got
Right.
rear-ended. They weren't doing anything wrong.
Yeah.
They're just going about their day. And so it makes it even scarier because it's like
Yeah.
this could happen again at any moment. And that's a constant fear that they're dealing with every single day of their lives.
Absolutely. Yeah. I hear it all the time when, patients come to me and tell me that, they can't get in a car anymore. They can't drive anymore. It takes a long time of that rehabilitation with a psychologist before they can actually feel more comfortable even getting in a car.
Yeah.
It's real common. And then from an interventional standpoint, I should mention that there's actually a procedure called a stellate ganglion block, and there's basically a little part of these nerves in your neck that help with there's a part of your nervous system called the sympathetic nervous system that when that's wound up, it increases the anxiety, it increases the level of the stress that kind of compounds itself. So when we do these blocks, actually it relieves their anxiety a lot. So
Will this block just sever the nerve, or at least let it chill out for a couple months? What exactly does it do?
Yeah, it just kind of paralyzes it and calms it down. It doesn't sever it,
Okay.
but it just calms it down. So a lot of they're using this very commonly. The VAs are using it.
Yeah.
A lot of these combat victims are coming back with PTSD.
Yeah.
And it's been approved to do these injections because the science is there, and these people are getting a lot better after these blocks.
And how long does the block last for?
And everyone's a little different. And so some people, you may need to repeat it a few times. And it's not going to completely cure it, but it's just going to make it much more tolerable.
Got it. And
Yeah.
will it last for a couple years, couple
Yeah,
months? Or
probably 3 to 6 months, and you might need it a few more times while you're getting the psychological therapy
Got
at
it.
the same time.
But you're basically allowing them to not be, at the level stressed out that they would be by giving them that block. And then
Right.
it gives them time to actually work through the mental aspect of it, which could take 2 years. And so they might need a couple injections over that time, but then
Yeah.
finally they emotionally will get over it and they won't need this block anymore. They've learned to control their own emotions in some way.
Exactly. It just kind of takes the edge off of that acute, more less tolerable
Yeah.
feeling that they get. And then, and also these blocks, they don't have the side effects
Yeah.
that some of these other medications do. Like some of these meds have, for example, Xanax is probably a very common one, but it's highly addicting. It has a lot of side effects.
Huge problems for dementia later on in life.
Right.
That's one thing. My girlfriend works as a nurse, and she says a lot of her older patients, they took a lot of Xanax, and they just like go crazy at like nighttime. They forget things. Dementia is a huge onset because of it.
Yeah, that's one of our goals as an interventional spine or interventional doctor, is to try to calm their pain and their anxieties with procedures that don't have those side effects of a lot of these medications do.
Yeah.
You know, so
100%. So we talked about, okay, so in the beginning of the case, right, 4 to 6 weeks, or sometimes even longer, because, you know, every case is different, right? It's not always going to take 4 to 6 weeks to recover from injuries. So if the conservative care does not work and they've been doing physical therapy, they've been doing chiropractic, and they're not really getting better, what is the next step? They come back to you, right?
Yeah.
Another consultation, and then what happens from there?
So from there, what we'll do is we'll talk to them about some of these interventional procedures that we do, and nobody wants to, you know, volunteer and get a needle in their back or anything. So they're usually, you know, they're a little hesitant. So we kind of have to explain how we do them and the safety behind the equipment that we're using, and we will go through and explain, like, you know, you've been trying all these treatments, and so far it's not working, and so now we should step it up to something a little more aggressive, invasive, or interventional. And so we'll talk about, for example, the bread and butter procedure. What we do is for a disc herniation would be that lumbar epidural steroid injection, or a cervical in the neck, but an epidural steroid injection. And so maybe we should talk about that a little bit and what that is. And so essentially...
So we're going to talk about, guys, going forward, we're going to talk about what is an epidural, okay? What is the procedure? What is involved with the procedure? And so for anybody that's interested in what an epidural is, we're going to break it down and go through it simply here and take it step by step. Okay,
sounds good. So let's say, again, we did our history, and this person has lower back pain, and it's radiating down their leg, and let's say it's shooting down past their knee, and it's going into, like, towards their ankle. And then we do the physical exam, and we find that they have some weakness with, so for example, when you bring your ankle up like this, pointing it up towards the sky, the L4 nerve controls the muscles that do that. So if you have weakness with that, we call that dorsiflexion, which is essentially moving the foot up this way. So let's say we have a reflex, we do the reflex testing, and it's missing on the right knee, which is the L4 nerve. So it's kind of, everything is telling us that this might be an L4 nerve damage. And then we get the MRI, and at L4-5, which is essentially right here, the MRI says there's a disc protrusion at L4-5. Okay. So that's textbook. It's not always textbook, but what I'm describing is sort of the textbook of what you read in terms of, if somebody has an L4 nerve damage, they'll have radiating pain down their leg. It'll come to the medial side, the inside of their distal leg past the knee, and then they may have some sensory deficits to light touch and pinprick in that area, and they'll have the missing reflex or a weaker reflex, and they may have some weakness in the muscles that are supplied by the L4 nerve, so that L4 nerve actually tells certain muscles to move. Okay. And so everything kind of matches up that this is an L4 nerve problem, and the L4-5 disc is sticking out and pinching on the L4 nerve.
Got it. And you'll usually have an epidural, or not, sorry, an MRI at this point, so you can actually see the protrusion itself on the imaging. Right.
Yeah. So then, and so we'll look at the images ourselves, and we'll assess the nerves, and we know the way, the anatomy, where they travel, and certain disc protrusions will pinch on specific nerves, and based on looking at the nerves, the MRI, we can tell which nerves are being compressed. And if that matches up with everything we just described in terms of the L4 nerve damage, then we pretty much have kind of figured it out that that's the level where the problem is. So then we want to put medicine at that level. And how do you get medication down to that L4 nerve of your spine? I mean, you can take an ibuprofen and, you know, go through your stomach, and it gets kind of spreads through your whole body, and a very small percentage of that through your bloodstream might get to your spine, and some of it might get to that area, but it's going to be kind of spread out through your whole body. Okay. You know, and you have side effects, like you can get stomach irritation, you call it gastritis, or actually if too much ibuprofen, you could have a stomach ulceration, or you can start bleeding. And they've also found that like these medications increase blood pressure, which increases your risk of a heart attack.
Yeah.
So you know, you can do that for so long, but after a while you got to say that's it. I mean, there's you can't keep doing that. You know, it's just sorry about that. I think I was getting a call. So we say, look, this is not good in the long term. I mean, we've been trying this stuff and it's not working. So what if we take a super powerful ibuprofen in a liquid form, and we bypass the kidneys, the stomach, and the heart, and all the organs that get affected if you take too many pills by mouth.
Yeah.
And we use a needle to put it right on top of the problem, and it'll be concentrated. So it's like 100 times as powerful and fully concentrated right on top of the problem. It will work a lot better.
Yeah.
Most of the time. So that's what an epidural injection is essentially putting anti-inflammatory. Steroid medication is essentially an anti-inflammatory.
Yeah.
And if you put the anti-inflammatory steroid medication right on top of the area where that's inflamed, it reduces the inflammation, and those inflammatory chemicals are what cause pain.
Okay.
And so once you reduce the inflammation, you reduce the pain, and then they can actually they can start to move around. And as they move around with less pain, they get more blood flow, and it kind of heals naturally again. And that disc could potentially go back into place after they've had the epidural, because it relieves the pain.
Got it. So you're saying by reducing the inflammation, it allows the person to go back to their normal activity and their ranges of motion. And by increasing their activity, their blood flow, which heals the entire body overall, will help them recover from this injury specifically in a more effective manner.
Sure. So yeah, the goal is, how can we get that disc to go back into place without having to, invasively do surgery?
Yeah.
So we try the therapies. That doesn't work. Then we try these injections, and we try to see if we can get that disc to go back naturally.
Yeah. Do you actually have an epidural needle with you today?
I do. I brought one. I wanted to show it to you guys.
So I would love if you could walk us through a procedure. Let's say for this procedure specifically, like what would be done? Does the person come into a surgery center? Like, do they do it in an office, or what exactly goes on there?
Yeah, we prefer that it's done in a surgery center. That's the proper way of doing it. That way you're in the most sterile environment.
Yeah. And
you have all the equipment there, and you have all the people there in case something goes wrong.
Okay.
Some people may do it in their office, but if I was getting this done, I would want it done in a surgery center with all the proper equipment and in resuscitation or whatever was necessary in case something went wrong. It's also done in a sterile environment. So we're getting close to the spine, and the spine is connected to the brain, and if you get bacteria that seeds down into there, you can get a meningitis. I mean, it can be life-threatening. So
it could be catastrophic for them.
Yeah, it could be very, very dangerous. So we want to do it in the proper environment, which would be an operating room setting.
Yeah.
So what happens is what we'll do is we'll have the patients come in. We're going to have them lay on a table. So there's kind of a flat diving board table that they lay on. And so they're lying on their stomach. So this is the back of the spine. So face down. So face down, and that allows us to see these openings here. And a lot of women are familiar with the term epidural because they get these injections when they're trying to have a baby, and it sort of anesthetizes the lower half of the body. So the epidural is the epidural space is an anatomical space in the body. That's all it is. So there's a covering of the spine here called the dura. And so that's basically the spine is sitting inside of a fluid-filled sac, and the outside of that sac is called the dura. And so when you do an epidural injection, so outside of the dura is where the medication is going to sit.
Okay.
So you have here, essentially there's a covering across here, and that's called the dura. Okay. Okay.
And is that muscle, or what is that material?
It's kind of more of a ligament.
Okay.
Yeah. So there's actually a ligament called the yellow ligament, and then below that is the epidural space, and then below that is the thecal sac, which is that's the covering that surrounds the spinal cord.
Okay.
So the thecal the dura, like we described, is covering the spine, right?
Okay.
So epidura means outside the dura. Epi meaning outside.
Yeah.
So the term epidural is outside the dura. That's where it comes from, epidural.
Got it. And that's because the fluid from the herniation has leaked into that space.
Yeah. So, well, that's just an area that if we get the because there's a covering over that called the yellow ligament. So when you get medication into that area, it'll stay there.
Got it. So it'll seep into that area.
It'll just kind of stay concentrated right in that area. Yeah. So it'll spread over to the nerve root. It'll spread around to the disc herniation. So the idea is to get medication over to here.
Got it.
Right? And there's two ways to get medication. You can either put the needle here and inject essentially into here, and that's called a transforaminal epidural injection. It's more direct. Or you can come from the back hole, and there's a hole in the back. So right here.
Okay.
And if you come through here, it's called interlaminar. These are the lamina, so between the lamina is interlaminar. And it's called an interlaminar epidural injection. So basically, as you pop through here, you're a couple millimeters away from the spinal cord or canal, and that's where you end up. That's the epidural space. And when you inject, there's a covering here. And so if you pop through that covering called the yellow ligament, or ligamentum flavum, now you're inside. And then when you inject medication in here, it'll come and it'll spread through here to the other to this side. It'll kind of wrap around this area to the front. So if you put enough volume, it should wrap around and get to this area. Sometimes it doesn't.
Yeah.
And so sometimes we'll say, you know what, that injection didn't really work. Let's try it this way. And we'll put the needle closer to the disc and where the nerve is. It's a little riskier. There's some blood vessels here that you don't want to get into. And this is kind of a little bit safer in terms of those blood vessels, which is why we usually try this first.
Got it.
And if that doesn't work, we might try one like this.
Okay, that makes a lot of sense. So you almost put it in the back middle part, hoping that it's going to spread enough over everything and heal it, and then it's also less riskier for the patient because you're not risking nicking any blood vessels or putting the medicine in blood vessels when you go through the transforaminal, which is on the side.
Exactly.
And many times you will know directly whether it's left or right based on the imaging and based on what they're feeling in pain. So you have a better idea of where that pain's coming from.
Sure, yeah. So if they say it's their right leg that, we decide to diagnose that this may be a L4 radiculopathy, which means the nerve is irritated or pinched on the, so then this is the body like face down. So this would be the right side, this would be the left side.
Yeah.
So if you wanted to do a right L4 block, you would put it here. On the right side, and if you wanted to do a left block, you'd put it on this side.
Okay.
And when you do that interlaminar procedure, you can go right and left to midline.
Okay.
So that most of the medication will go to one side or the other. When you do that interlaminar approach, which is the first one we try, it usually spreads up 2 or 3 levels. So it's kind of more of a blanket injection.
Okay.
And when you come through this side hole, you usually inject less volume because you're right next to where the problem is.
Okay.
And it's more of a diagnostic and a therapeutic injection in terms of it can actually tell a surgeon if that's the right level to do the discectomy or surgery at.
Okay.
So part of what we're doing is relieving the pain, but we're also doing it in a systematic algorithm in terms of coming up with the diagnosis and leading towards if they needed surgery to tell the spine surgeon, look, I did this injection here, it didn't really work, then I did it here, and they had a lot of relief for like a few weeks or however long, and that will tell the surgeon that might be the level that they need to address.
Okay. Very interesting. Okay, so you're almost like allowing you're doing your own diagnoses by figuring out where the pain is coming from, and then if you've done multiple epidurals, let's say over a series of a year or 2 years, that this is the information the spine surgeon might need if they do have to go in and do something more invasive. And we won't get too much into what spine surgeons do, but you essentially can provide the information that a spine surgeon would need to even do his job properly.
Yeah, exactly. So we would try these injections, and hopefully, if they're not getting better, we'll get them to a surgeon before a year or two. We'd like them to get fixed quicker.
Yeah.
But we might do 1 or 2 or 3 injections in order to get to that point where we know which level to do the surgery at, and also we've confirmed it with these blocks, and we. We don't want to just give too much steroid where we keep on continuing to do injections. If they get 1 or 2 or 3 injections and they get better, great. If they're, but if they're continuing to need these injections where it's kind of wearing off quickly, that's where you want to try to get them surgically fixed then at that point.
Got it. And so let's end this conversation about epidurals by just talking about what is exactly are you injecting into the spine? What is the medicine?
So there's that corticosteroid that's an anti-inflammatory. There's one called, the one that we use is called dexamethasone. And the reason why is dexamethasone is non-particulate. And what that means is that it's actually like, if you look at the bottle, it's clear. You know, it looks like water. I mean, in terms of when you're looking at the consistency of it. There's other steroid medications. When you look at it, it's kind of cloudy and it's kind of like, it's white.
Okay.
And so that's because, imagine if you took a pill and you just crushed it up in a tiny little glass, or I mean, a glass with water in it, and you crushed it up, and essentially there might be these tiny little rocks in there. You know, it's not going to be completely ground up.
Yeah.
And so some of these steroid medications are like that. They have the little particulate matter in there, and those can actually they can, if you inject that into a blood vessel, it can be dangerous. I mean, some people have had spinal cord injury or even death.
Okay. So what is the name of that medicine one more time?
So the one that's clear with non-particulate is called dexamethasone.
Dexamethasone.
Right.
Okay,
and so that is a corticosteroid, which is basically a super powerful liquid form of an anti-inflammatory medication, like a super powerful ibuprofen.
Okay.
And so you inject that, and we mix it with a little bit of lidocaine. Okay. And then we sometimes mix a little saline, but
and lidocaine is a painkiller, right?
And so lidocaine is an anesthetic medicine that just basically numbs up the nerves temporarily. Okay. But that wears off in a few hours, like a couple hours. So when they first get the injection, they get off the table, they're feeling great because of the lidocaine.
Yeah.
And it's kind of all numb. But that'll wear off in a few hours, and by the time they get home, the pain might start coming back.
Got it.
And then that steroid medication takes a couple days to kick in, because it takes a few days for it to really reduce the amount of chemical inflammation there.
Got it. So it's not instant. The only instant relief that patients might find would be from the lidocaine itself, which will last a couple hours. But then typically it takes a couple days. When you say a couple days, 2-3 days or 4 or 5, like what range exactly?
Yeah, I would say 2 to 4 days. Yeah, most of the time it's 24 to 48 hours, and they start feeling the effects.
Okay, got it. And then the medicine at that point will start having the anti-inflammatory response, and then their spine will start feeling a little bit better.
Yeah, yes, and I've had people with one injection, and their pain's gone. You know?
That's amazing.
Yeah, it's like they've been on, a lot of them, they've been in therapy for 8. They've been suffering for 8 or 9 months. They've been in therapy 3 or 4 months, and they're still in pain. They've tried all these other treatments. They were afraid of the injections, and they try all these other modalities, and they're still in pain. And all of a sudden, they're finally willing to, at this point, try one injection, because they're so desperate, they're hurting, and they're we talked about how it affects their emotional status. So they're now finally like, okay, I'll try this, and they try it, and bam, their pain's gone.
Yep.
So they're pretty impressed, and they're like, wow, Doc, I wish I would have done this in the beginning. I should have just done this first.
Of course. I mean, once again, there are obviously risks involved with sticking a needle into your back, and so you want to try conservative first if possible to try to get better, and then this is the next step.
Right.
Okay.
Yeah.
So that's what an epidural is. So next I want to get into, because you were talking about diagnoses, and I know that one procedure that you guys do specifically is, let's say you might not know where the pain is coming from, or you're trying to figure it out. It's in a general localized area. So you do things called facet blocks, correct?
Yeah.
And so I would love if you could break down, what are facet blocks and what are their purposes and what's the procedure?
Yeah. So I'll tell you, like, I would say in my experience, when people come to us and we're going to consider doing an injection on somebody and actually using needles, we better be pretty confident about putting that medicine in the right spot.
Yeah,
nobody
wants to come in or have an accidental injection in the wrong place that didn't do anything for them.
Right, because then they're like, what did this guy do? He stuck me with needles, and it hurt, and nothing happened. It didn't work. I don't want to go back to that guy. So we want to be very precise in our placement of these needles. And so in my experience, 30 to 40% of the time when somebody comes to me with neck or back pain, it's usually a problem with their discs. But I think a lot of people forget that the other 30 to 40% of the time, it's actually their bones. Okay. And it's not the discs. And what's so important about that is that on an MRI, which we talked about as imaging soft tissue, MRIs are not good at imaging bone, and the x-rays don't really show you whether the bones are inflamed or not. So when you're doing MRI, you're focused on the discs, and a lot of people get focused on the disc. Well, like, okay, there's a 2 millimeter or a 3 millimeter, and they get focused on that because that's what the MRI shows you. But it doesn't show you the damage of the bones. And the way, like we talked about, the design of the spine and the bones that are there to protect the spine. And when there's a force, that pushes you forward or backward, or a compressive force, this is the neck, it's going to whip back and forth. And when it does that, it's stretching the ligaments that are on the outside, it's damaging the discs, and it's also causing these bones to smash on each other. So, and so you see the way the spine is designed, those bones are protecting the spine. And a lot of times those bones will smash and jam up on each other, or they'll start to get out of place and be twisted and kind of stretched out, because they're, like, for example, where this bone meets that bone right there's a little crack there. Yeah. That's called a facet joint. And so you can see here, so for example, where this bone meets that bone, right in that crack, that's called a facet joint. Okay, so you can see you have a facet joint there, you have one there, you have one on each side of the spine where those two cracks meet, where the two bones meet. And in that little crack is called a facet joint.
Yeah.
So you can see that you have a facet joint on each side of your spine, on this side and this side, on both sides, all the way down. Each level has a facet joint. And these facet joints, essentially, it's just like a knee joint or any other joint in your body. It's got fluid in it, and the fluid allows those bones to glide. And those bones, as you move and twist, those bones start to kind of glide on each other, and they're supposed to glide smoothly. But what happens with pain, with stretching or inflammation in that joint, is that fluid, it gets sort of pushed aside, and so now it's bone on bone. And now as you move and twist and turn, those bones are grinding on each other.
So the fluid in between those, so in those facet joint spots, can get pushed to the side, and then, like, does it naturally come back, or, like, what's the situation there?
Yeah, so with inflammation, you can get irritation, inflammation within that fluid, and then there's less fluid available, and it kind of just, then it kind of squirts out, and basically you're left with bone on bone grinding.
Okay.
And so when these bones grind on each other, you have it's painful, and there's a lot of little, like, receptors, these little, like, kind of sensing organs, that are like little radars that are in there, and those get turned on saying, hey, this hurts, it's painful. And there's a message that travels along this one nerve called the medial branch nerve.
Okay.
And so your main nerve root that we talked about that comes out at each level, there's a branch that comes off of it. One of the first branches that comes off of it comes back and it travels medially. Medially meaning towards the spine. So if it traveled laterally, it would be out that way. If it traveled medially, it would come back towards the center of the spine. So this branch basically travels this way. It's called the medial branch nerve because it travels medially, and it's a branch off the main nerve root. And that medial branch nerve supplies sensation to the facet joint. And so what we can do to test to see if specific facet joints are causing the pain is numb up that medial branch nerve. And
is that what a medial branch block is called?
Yes.
Okay.
Exactly. So in order to come up with the diagnosis of facet pain, there's only one way, and this has been studied, and a bunch of articles have been written about this, but the only validated way to diagnose facet pain is with a medial branch block. And so if I use a chemical like we talked about, that lidocaine, right, that we mix it in the epidural, and it only lasts for an hour or two. So if I use just lidocaine, no steroid, just lidocaine, and I drop use a needle to get the needle right to that medial branch nerve, which, keep in mind that nerve is here on the outside of the bone. So it's pretty safe. I mean, you touch the bone here, you're pretty far away from the spinal cord.
Yeah.
And, like the epidural injections, you're inside there and you're right next to the spinal cord. But with these facet blocks, you're hitting the bone, so it's pretty safe.
Yeah. There's less risk.
Yeah, much less risk. But we got to do it at whichever levels we think are causing the problem. And if I drop a little bit of numbing medicine on that medial branch nerve, and that's the nerve that supplies sensation to the facet joint that we think is causing the pain, then theoretically, because we said it lasts an hour or two, their pain should go away for an hour or two. And that's it. And so the pain would come back after a couple hours. But if we do the block and then we give them a little pain score diary where they write their pain score every half hour, and then right after the procedure, right before the procedure, let's say their pain like is a 7 out of 10 or 8 out of 10, which is pretty severe. And then we do this block and we say, how's your pain? And they say it's gone. And we're like, okay, well then we'll just mark that down as a 0 out of 10. And then a half hour later, we say, hey, how's your pain now? And we have them move and twist into specific positions that were causing the pain.
Yeah.
And if they go, well, now my pain is still only a 1, well, that's great. And so let's say we do that every half hour, and we notice that after about 2 to 3 hours, the pain goes back up to an 8.
Yeah.
But for the first few hours, the pain was down to 0.
Okay.
So that helps us, that just kind of confirms that that is the nerve that's sort of a communication wire that is communicating pain from the joint to the spinal cord and then up to the brain.
Okay, so you are able to diagnose exactly where the pain is coming from, right? So let's say that you did hit the right place, and you're telling me that the facet blocks only last a couple hours, so you can actually just diagnose it.
Right.
And then what is the procedure that you use to fix facet pain?
So that's a very good question, and that's really the answer is the treatment for facet pain, and that's called a radiofrequency ablation.
Okay, so an RFA correlates to a facet block.
Yeah, exactly. So the facet block is a test block to see how it would feel if you did the RFA without doing the RFA.
Okay, so right now we're going to get into what is an RFA.
Sure.
So, for all of you listening, this is a good precursor to understand that facet blocks are basically the stepping stones to getting to an RFA. And it sounds like you need to do them to make sure that you know exactly where the pain is coming from, so that you're not, like you pointed out, doing too many procedures that are unnecessary or doing any procedure that's unnecessary.
Correct.
And so now we've done the facet block, you've determined it's coming from this specific pain trigger, and now you're going to do an RFA. So what is an RFA?
So an RFA stands for radiofrequency ablation. It's also known as a rhizotomy. That's just another term for it. But essentially what you're doing is you put a needle down to that same medial branch nerve, and when you get to the nerve, instead of injecting the lidocaine on there, you're going to put a probe through this needle. And the probe, this probe is connected through a wire on the outside of the body to this machine, and it's called a radiofrequency machine. And when you turn on the radiofrequency waves, it actually stimulates that electrical wire, and the tip of that probe gets very, very hot.
Okay.
And so it gets extremely hot, but it's just the very, very tip.
Okay, so
you
have a wire that you're heating up with radio frequency waves, and then the very tip gets very hot, and that's what you're going to use for the procedure.
Yeah, so you have like a metal probe that is actually going through this needle, okay? And the probe is maybe that big, and it's kind of a flexible probe that's made out of a metallic material. And so when you put it through the needle, the tip of that probe will just extend out a little bit past the tip of the needle. So it's kind of sticking out of the needle. Okay. And it's like a little metal thing that's just sticking out of the needle. And that's basically you put it down to right where you think that medial branch nerve is.
Yeah.
Okay. So, and now that probe is coming through the needle, and now the needle is basically stuck through the skin. So now it's coming out of the top of the hub of the needle. And from there it's connected, it's a wire. And that wire is traveling to like a machine that's set on the side of the on some type of table nearby. So that wire is connected through the hub of this needle and this probe, and then it becomes like a metal flexible probe, and the tip of it gets super, super hot. So when you turn on the radio frequency waves, it makes that tip get really hot, and it essentially burns the nerve off.
Okay.
So using heat, you can actually destroy tissue.
Okay, and you're burning the nerve that's on the medial branch block, like the medial side, correct? So like in that facet joint, you're basically burning that medial nerve.
Yeah, so some people will treat the joint. Like for example, when I compare it to a knee, I think it's easier for people to conceptualize. So imagine if your knee hurt, you could either inject medicine in your knee, or there's a nerve that supplies sensation to the knee, and is traveling to the spine and telling your brain that my knee hurts, you could either cut that wire or you could inject medicine into the joint. So what we're talking about doing is cutting the wire called the medial branch nerve.
Okay.
So you block it using numbing medicine to test it.
Okay.
So they could see, so they could feel what it would feel like if it was burned off without burning it off. Because once you burn it, it's permanent. So we want to test it first.
Got it.
So it's like, you don't want to just go and start ablating nerves and burning them off, and we know, and then go, oh, I'm sorry, that was the wrong one, but we just burned it off. So you don't want to do that.
No, of course.
So what you want to do is say, okay, let's test it. We have this theory based on your description of your pain and based on my physical exam that your C5 and 6 facet joint, 5-6 facet joint is causing the pain. So let's go ahead and block the C5 and the C6 medial branch nerves. Those are the nerves that supply sensation to that facet joint. And if the pain goes away, it confirms that the pain's coming from that joint. Okay. So then when you heat up those same nerves and burn them off and destroy them using heat or radiofrequency ablation, now it's a permanent block.
Got it.
Yeah.
Okay, and so you're saying that block will last the rest of their lives.
Yeah, so those nerves are peripheral nerves, meaning they're not central nervous system. It's your brain and your spinal cord, and any nerves that come off of that are considered your peripheral nervous system. So those nerves can regenerate,
So they can
they can come back, and they usually do. And so it'll take about 9 months to a year, though, based on the size of the lesion that we create using heat. It takes about 9 months to a year, usually, sometimes longer, sometimes shorter. But I would say if you can get 6 months, we consider that a successful block.
Got it. And so with this block, you're trying to give the patient or the body a chance to heal to where almost that fluid will come back to create that separation so that bone is not being irritated on a regular basis.
Yes.
And same thing with epidurals. You're giving people a chance and their body a chance to move naturally, increase that blood flow, and heal on its own instead of going the major surgery route.
Yeah, exactly. Yeah. So we're trying to kind of help them to heal on their own using these procedures. So it's sort of so they can avoid surgery. Yeah.
Got it. And so with the epidural, you're trying to avoid a discectomy, which would be a surgery to remove a piece of the disc. Yeah. And then for a facet block RFA, you're trying to avoid a laminectomy, right? Where you're avoiding taking a piece of the bone.
Yeah, well, the laminectomy is more for the discectomy. It allows them to access to where they can get to the bone, to the disc. So the laminectomy is more a part of the discectomy. There's really no surgical treatment for facet pain.
Okay.
The most aggressive surgical treatment is this rhizotomy.
Got it. Okay, so they would just come back every year or every couple of years for another RFA or a rhizotomy to get that nerve end burnt off.
Right. So I would say 40 to 60% of the time, and everyone's a little different. It develops into a chronic pain issue.
Yeah. And so for this, sorry, I didn't mean to interrupt you.
Okay.
For this procedure, when you're going in there and putting that needle on there, how do you get in there? How do you guide it to that exact location?
So for the facet blocks?
No, for the RFA.
Oh, for the RFA, yeah. And it's the same actually for the blocks, but what we do is we have a specialized camera, and it basically is shooting images through the body. It's called a fluoroscope, and so with this camera, I can take pictures. So as I stick the needle through the skin, I can take a picture and I can see the tip of the needle.
Got it. So
and I can see all the bones.
While they're laying there, they're getting X-rays basically done of them live as you're doing it, and that's why I've seen these procedures done. Everyone's wearing gear because there's being X-rays taken at that moment.
Exactly. So we have a lead shield that we're wearing because this fluoroscope does give off a little radiation. So we have to be properly protected. Not enough for the patient to have an effect on the patient because they're just getting one procedure.
Yeah, but you guys are in there regularly.
Right. We're in there all day, multiple times a week. So we're getting a lot more exposure. So we wear the protective lead. So anyhow, what we'll do is we'll take pictures the whole time as we're introducing this needle, and we want to know, oh, we're too far to the right. Let's go ahead and kind of bring it back out and lean it a little bit, aim it more to the left because we want to get it right on top of that edge of that bone.
Yeah. And
so we know where the anatomy of where these nerves travel. There's been enough, studies and enough cadaver studies to. There's a guy named Nikolai Bogduk who's kind of sort of the godfather of interventional pain, and he did a lot of the work on really uncovering where these nerves travel, along what part of the bone, where. And so we've been able to, through his research, figure out exactly where these nerves travel. And we can, when we do that x-ray, you can see the bony picture. You can see where the bones are, and you know, based on where the bone is, where that nerve travels, and you essentially pinpoint down and hit it right on top of where that nerve usually travels. And it creates, you know, a big enough lesion where if you're off by a few millimeters, you're still going to hit it. You're still going to burn it. So essentially, using this fluoroscope, we're able to guide the needle into the right spot safely.
And then that will go through the needle to go in there and get the work done.
Yes, exactly. So we just got to be very careful. I mean, when we're doing a medial branch block, we're putting the needle, like for example, the medial branch comes off of the main nerve root. These are the main nerve roots here. And there's one branch that travels right through here and goes up into the facet joint. So we actually want it to sit right here. So for example, an epidural injection might be back in here, but a medial branch block, we set the needle there. And just kind of, we know that this nerve travels right in this groove here and comes out and supplies sensation to these facet joints. So if we set it right there and turn the heat on, it should get it.
Perfect.
And so we'll test it. We'll kind of, you can stimulate the nerve with electrical impulses to check and see if you're nearby. And if you're too far forward, which you can see, there's not very far.
It's not going to stimulate it.
It needs to be here, right? But if you go too far and you're right here, now you're touching the main nerve root, right? And if you were to turn the ablation on, they'd be paralyzed permanently. So there's a lot of risk involved here. You know, this is not just, you know, this quick, easy procedure. I mean, this is you know, you have to do it somebody who's properly trained. You don't want to just go to anybody to do this procedure because, you know, it has to be placed properly. But when you place it properly and then you do the proper testing with the stimulation, because if you're down here and you test, their arm might start to kick, you know, but if you're up here and you test, their arm won't kick. So you could do some testing first.
So you'll do like little shock, like little bit.
Electrical stimulation.
Yeah, just very tiny, just to see if it has any effect on them, so you know you're at the right place.
Yeah, so you can actually stimulate the nerve with electrical impulses without heat. So it doesn't damage it, it just stimulates it. It just makes it kind of fire.
Kick a bit,
Yeah, so you can do that, and if you're in the wrong area, you'll know because the whole, your whole arm might start kicking. Or if you're down here in the lower back, and you're doing the facet blocks, for example, to do a block at this facet joint, the medial branch nerve sits right, like basically, so it comes off. So here's your main nerve root. There's a branch that comes right down over here, and see where this part meets that part?
Yeah, that's the groove.
Yeah, right in that groove. It travels right through that groove and then comes back medially and goes right into this joint.
Got it.
So the point we want to be at is right there.
Yeah.
And sometimes when we do the ablation, we actually come in a little bit because it's traveling along here.
Yeah.
So we'll try to get it parallel to the nerve and do the ablation. But if we're way over here and we're touching this nerve and you turn on the stimulation, their whole leg will kick.
Yeah.
So before you turn on the heat, you're just electrically stimulating it, which is fine. It's safe. It just kind of turns the nerve on for a second, but it doesn't do any damage. So when you do that stimulation, if their leg starts kicking, you know you're in the wrong spot. You better not turn on the heat. You better readjust that needle, take some more pictures, and make sure you're here.
Yeah.
So eventually, once you're here, and you can tell by doing the x-rays where you're at, and we do different pictures, you know, AP meaning in this direction, or lateral this direction, or sometimes oblique where you're taking a picture at an angle, and you get all those images, and you check all the different angles and make sure your needle's in the right spot.
Got it.
And then you do the testing, and once you do the testing and you're cleared and there's no, you know, their leg's not kicking, their arm for the neck, then when you're ready, you numb it up first so they don't feel the burning.
Yeah.
But you put a little bit of that lidocaine that we talked about just to numb it up. And then you turn the heat on. When you turn the heat on, they don't really feel that burning because it's all numb at that point.
Yeah.
But it basically just destroys that medial branch nerve, and then essentially the facet pain goes away immediately. And then so as when the pain's gone, like you said, they can start to move around a little more. That facet joint can heal And if they go to maybe the right chiropractor, and they can sort of be aligned in the right position where that facet, there's a capsule around the facet joint, and sometimes it can be stretched if they're twisted. So for example, if we were twisted this way, you could see that the facet joint here is going to be stretched, and that even that stretching can cause a lot of pain. So if you do that rhizotomy, and then you have them realign the spine so it's kind of back into its normal alignment, then those facet capsules are no longer being stretched, and they can start to heal. And then with that healing, when that nerve does grow back in 9 to 12 months, that they're no longer feeling that sense of irritation, inflammation, and pain, and the nerve will eventually grow back, but there's no longer any messages of pain traveling to the brain at that point, hopefully. And like I said, sometimes they develop where it doesn't heal so well, and a certain percentage of people will develop a chronic pain symptom in that facet joint, and those people, you might have to do that ablation once every 9 months to a year for the rest of their lives.
Got it. Okay. And there's not particularly a surgery that might be able to solve that problem.
Yeah, no, not really. No.
Okay, understood. Okay,
Yeah.
so that's an RFA or rhizotomy. And so we've gone through epidurals, we've gone through rhizotomies and RFAs, and you said that there's one other type of procedure that you actually just told me about earlier today that you're able to perform, which is an endoscopic surgery almost, or it is a
Right.
surgery.
Yes.
And so I would love to talk about that.
Sure.
And this is the last procedure that you guys really provide
Yeah.
as pain management doctors, and I would love to kind of get into that, and we can kind of end there, and then I want to talk a little bit about you as an individual.
Okay, sounds good. Yeah, so the endoscopic discectomy it's a discectomy means removal, right? So discectomy means removal of disc tissue. So
Okay, so this is called an endoscopic discectomy.
Yes.
Okay.
So the endoscope is a scope. It's a rigid scope, and I have one here. I brought one, and so this is what it is. It's basically there's this long tube, and there's actually a camera that attaches to this end, and it actually can shoot a picture, and there's things in here so it can actually bend the image and make it shoot this way. And so with the prisms in there, that you can actually connect a camera to here, and you can see on the end of it, and you can see that inside of here there's actually a few holes. Okay, and so this is called an endoscope. And so then there's another attachment for light, and you can actually turn on the light so you can actually see through this end.
Okay.
So going back to this thing about the disc herniation, we try the conservative care, it doesn't work. Let's try an epidural. That kind of helped, but not permanently. And they're back again, and let's try a transforaminal injection and see if that's really the level that's causing problem, and maybe get better medication to directly on top of where that disc is compressing that nerve. And let's say that works for a good couple months, but then the pain does come back. Well, then that tells us that is the problem, because the pain went away when we put the medicine there, but the injections are just kind of temporary. But so this patient's looking for a permanent fix and says, look, these injections are working, but I still have the pain's coming back.
Yeah.
So then we finally get to a point like, well, let's try to see if we can then remove this disc tissue. So this part that's sticking out here,
Yeah.
you may want to just take that out and just take that piece out. But how are you going to get to that? So usually doctors come from the back, right? So if you're coming from here trying to get this, you can see it's on the other side, and it's kind of on the side, and it's pretty much closer to the front. So to get to that, you can either come through the back, or you can come through the side. So most doctors, when they do like a laminectomy and discectomy using a microscope, that's what they consider the minimally invasive way of doing a procedure here. They'll come through the back, and there's not enough space to get through here.
Okay.
And so they'll actually take part of this bone off, and that's called a laminectomy. This is the lamina here.
Okay.
And laminectomy, like I said, ectomy means remove. So if you remove part of this bone here, it's called a laminectomy.
Okay.
And so they'll take a little piece off of here so they can stick their instrument down and look inside here. And so with a microscope, the microscope is they have a tube that they use, and then they can set this microscope up to the tube and look through it. And so the tube might be, an inch, a couple inches diameter.
That thing's pretty huge.
Yeah. So, I mean, they have some that are a little bit smaller, like maybe an inch, but it's still like, that big.
Yeah.
So they're having to make an incision about this big.
So they're like doing almost like a laminectomy with a discectomy sometimes. They're doing like a combination of the both.
Yes. So, and they actually have to cut through the muscles. Then they're taking away some bone, and that way they can kind of push the spinal cord out of the way to get to where that disc is. And then they'll look through a microscope and have their instruments in order to grab that disc tissue. But what we do, and what's kind of the more cutting edge way, is using this as the access tube. And you can see how small that is. I mean, it's
like
I think
a couple centimeters, not a couple millimeters.
Yeah, it's probably about 8 or 9 millimeters wide. I mean, it's just, or 10, but it's not. It's less than a centimeter.
Yeah.
And you can imagine trying to do the whole surgery through this tiny little hole, and that's called endoscopic surgery, and that's kind of I think the future of spine surgery, because it's so minimally invasive, and the recovery is amazing. I mean, people 7 to 10 days after the procedure, and their pain's gone and they're back to work. I mean, their post-recovery pain from the surgery is.
So you're able to like remove a piece of the disc and pull it through that?
Yeah. So what we would do is we would get this, and we'd essentially get it down. So this thing is so small that it's going to slither through the muscles.
Okay.
You don't have to cut the muscles. It'll just kind of slither through them. And then when you so this nerve actually comes out near the top. So what we do is we'll put it down like right here. Okay. So now we know we're kind of right next to that disc, right? And instead of having to come through the back where all the bone is and the spinal cord is, and you have to push the spine out of the way and cut out all this bone so you can basically get to that from the back. What makes more sense to come direct through the side.
And you can't do that with the type of procedure that you're talking about from the spine surgeon.
You can't do that with when you do a laminectomy and discectomy using the microscope. You're coming from the back, and you can't come through the side here. Yeah, so you have to move the spine out of the way. The thecal sac that has all the nerve roots, and you have to take out part of this bone here. So you're taking out part of this bone so that you can get to this through the back, kind of off to the side.
And then that bone's gone forever afterwards. And what are the risks of that bone being gone?
Well, it causes it. So that bone, they just sort of shave off just a little bit there, so it doesn't really affect the stability too much. These facet joints also help with the stability, as well as these discs and the bones, so that everything is kind of structurally supporting the spine. But when you take a little bit of the bone off, it doesn't really do much. But when you, as part of the healing process, your body can develop like scar tissue. And also when you have to retract the spinal canal, and as you're moving that spinal, like the sac, which has all the spinal nerves, you have to kind of move it out of the way. That can cause a lot of inflammation and irritation. So that scar tissue can develop, and you have a lot of people after these more aggressive surgeries develop scar tissue, and they end up with what they call failed back syndrome, where essentially they're still in pain after the surgery. And you always hear about these people who say, well, I had a friend who had this back surgery, he's never been the same, and he's just in worse pain. And so those are the kinds of stories you hear about the more aggressive surgeries. So it makes more sense, again, going with our philosophy of the least invasive to the most invasive, that you would do this before you did something with a microscope, or before you did an open surgery, like with a fusion or something. So with this procedure, again, we're going to come down, and we're going to essentially come from the side and angle this right to where this disc is. Okay.
And just go directly to it.
And go directly to it. And then when we set this down to where this disc is sticking out, and a lot of times these discs are actually back inside here, pushing on the spine. So sometimes we actually have to set it all the way in there.
Oh, wow.
Yeah, so we can get to it.
You can really get in there, though.
Yeah, you can get all the way in there. Yeah.
That's amazing.
Yeah, so we can set it in like that.
Yeah.
Okay, and then it's so small, this hole, that you can't see through it on the other end because it's dark.
Yeah, of course.
Right? So how are you going to see through that? So that's where this scope comes into play. And what we'll do is we'll take this scope and we'll stick it through here. Okay.
Got it. And so those little tiny holes are where the tools go through?
Yeah, so now you have the light source and you have your camera, and on a TV screen you can actually start to see through here.
Wow.
And then so there's actually one hole for the light, and there's another hole for your instrument, and so there's another hole for fluid. So you connect the IV fluid line, and then you actually are running fluid through here.
Wow.
And so that way you can get better visualization when you have that fluid in there. So now let's say I have this down, and I've got this placed properly, and now I can put the camera through, and now I can see the disc, and I can see exactly where I'm at. I can, if you move around, you'll see the nerve and you'll see the bones, and you can kind of start to recognize the anatomy.
Yeah.
And so now that I see where that disc is, and I see where the piece is that's sticking out,
Yeah.
we're taking pictures with X-ray too, so we can see exactly where this is at. And so once we have it in the right spot, we'll take this, which is like a little grasper. It's almost like those things that how you see people on the side of the freeway picking up trash.
Yeah.
Right. It's like a mini one of those.
Yeah. Okay.
And it's called a rongeur, and essentially as you squeeze this in, it grabs.
That's awesome.
Right? So you can actually put this through this hole,
Okay.
which goes through this camera, and on the other end, you can actually grab tissue.
And you just pull it right out.
And you just grab it and pull it out.
Got it. And so you're pulling out all that extra inflammation and the material that's like leaked out.
Yeah, so what you're doing is that red part of that disc that you see here.
You're literally gonna pull that out.
Yeah, so you can see it here.
Yeah.
Right? And so you're gonna attach this here like that and grab that piece and start pulling those pieces out.
Wow.
And so you're only gonna take part of the disc that's sticking out. You're gonna leave the rest of the disc there.
Got it.
And so all you're taking is the part that's pushing on the nerve.
Yeah.
And so you're only taking out a very tiny part of the disc, but just the part that's actually causing the problem.
Got it.
And there's other more aggressive surgeries where they take the whole disc out and put a fake disc in there, or they put like metal rods and screws and fuse it.
Yeah, fusion.
Yeah, that's a fusion.
Yeah, we don't have time to get into that today.
Yeah, that's way more aggressive, and that's probably the last thing you would do. But the great thing is if you do this, and the pain the disc reherniates or something, you can always go to something more aggressive. But once you go to that last step, you can't go backwards.
Can't go back, yeah.
So this would be the next step, is to do an endoscopic discectomy, and do it and grab this tissue and just pull it out. And it's pretty amazing when you pull it out, you actually see this big old like worm-looking thing.
Yeah.
And it's the disc tissue, and it's pretty satisfying when you see this big disc, get pulled out, and it's amazing. Like patients think we do these procedures actually with mild sedation. They're not completely out.
They're not out?
Yeah,
I don't know, man. I'd want to be out for that.
Yeah. So part of the safety of this procedure is that if you're near that nerve, and they're somewhat awake, they can warn you, because they'll tell you. Those like, if I feel that it's down my leg. So, I mean, we do give enough sedation where their anxiety is gone, and they're completely sort of drowsy, and they might not even remember it. They might think they were out.
Yeah.
But there's just enough to kind of make them forget, and also so that they kind of are relaxed and not moving.
Yeah.
So the anxiety is gone, but you have that safety factor of knowing that if you touch a nerve that you don't want to pull out, because again, that can cause some permanent paralysis. If you were even to touch it, they would warn you and tell you that they feel pain shooting down their leg.
Yeah.
And then you'd know to kind of move or readjust it and change the angle of your instruments.
Wow. That's amazing. That's a really cool procedure.
It is. It's pretty amazing.
That's really amazing. Awesome.
Yeah.
Okay, wow. So today we've really gone through pretty much everything. We've gone from epidurals, RFAs, rhizotomy, same thing. And we've gone to endoscopic microdiscectomy is what it's called.
Yeah. It's called a lumbar endoscopic discectomy.
Okay.
Yeah.
Lumbar
endoscopic
discectomy.
Yeah. Endoscopic meaning this here is the endoscope.
Okay.
And so the other procedure, which is about that big of a hole, that's the microscope.
Got it.
So the minimally invasive surgery that you hear about that's more commonly performed that most surgeons are trained on is called a microdiscectomy using a microscope.
Got
But
it.
this is an endoscopic discectomy using an endoscope.
Got it. Endoscopic discectomy.
Yeah, so the
using an
endoscopic.
endoscope.
So yes, that's the pretty amazing, kind of the most advanced, the least invasive
Yeah.
way of doing a spine surgery and getting a disc out.
Yeah, I mean, what you guys do is amazing, right? It's the difference between giving people just Norcos or painkillers, having them get addicted to opioids, and not really doing anything, right?
Right.
You guys are actually getting in there, doing the work, and helping them recover in a more natural way, at least giving them the time to heal in a natural way, and
Right.
helping alleviate that pain during the process.
Absolutely.
Yeah.
Yes.
So I know we've talked about a lot about what you do today. Let's, kind of just, I'm going to wrap this up. I want to let's talk about you for a second here. Okay. I want to just ask you just a couple of questions. Who is the worst client, or what is the worst client you've ever had, and what did you learn from them?
Well,
Or patient, I guess it's not, is the proper
it'd be
term, not
patient.
client.
Well, I would say, when I first started my practice, I was treating general, chronic pain and anyone with any painful conditions. So we were getting a lot of referrals from primary doctors with people who were and on medications already and
Yeah.
high doses of opioids, and ever since there's been this huge scare of this opioid crisis, a lot of the primary care doctors are not comfortable prescribing these medications, so they might prescribe a few, and then the patients keep coming back for more, and the dose goes up a little bit over time, over the next months to years, and it finally gets to a dose because they become tolerant to a dose where it's now they're not comfortable prescribing it anymore. So then they'll say, go see the pain management doctor, and they'll come to me saying, hey, my doctor said you're going to be taking over on my pain medications. And so that's a difficult situation, and where we were doing a lot of that in the past, and so I would say those difficult patients where we've had a lot of difficult conversations with them on why they need to try to get off of those medications and do some of these procedures to try to relieve the pain and to fix them. So I mean, I think I've learned a lot over the years. I want to fix people. I don't just want to give them something that's going to curb the pain for a few hours and sort of numb their brain to the pain, but doesn't actually fix the problem.
Yeah, I think a lot of people don't understand that when you go to a doctor, like there's no getting better is work, right? And you have to put in the work. And the doctors, you want to go to doctors that are going to help you put in that work, but it's usually not going to be something that's going to happen overnight. And you need to understand it's a process, whether it's a combination of conservative care with pain management. But you need to realize taking pills is not the solution. And I think a lot of people out there think, no, I'm just going to take painkillers until forever, most of them. And that's not the way to get better.
No, absolutely not. And in fact, there's a thing called opioid hypersensitivity, and after time, your nerves become more sensitive to any kind of new irritation and the original pain. So they actually work in reverse, and you start getting more pain.
Yeah.
And then when you try to get off of them, there's all the withdrawal of the opioids, which is another horrible thing that they have to try to get through. And so, I mean, our goal is, after the first few weeks, you should not be taking any of these strong painkillers. You should be considering more therapies, the chiropractic and physical therapies, which relieve pain as well.
Yeah.
And if you get to a point where that's not working, then we start talking about these interventional procedures. So I think I've learned over time is I want to fix people, and I don't want to just give them a temporary kind of a temporary solution, and that's really in the long term going to cause more damage.
Yeah, I can agree more. And then let's ask you one other question, then we'll wrap this up. If you could go back and talk to little Sial, little Karam, and be like, hey, this is a piece of advice that I have for you, what would you say to him?
Well, I would just say to I would say not to give in to peer pressure. That's a big thing in high school these days. And, I'll admit that it's kind of embarrassing, but I was an ex-smoker. And I think I learned over the years. I mean, I'm very athletic, and I like to work out and stuff. And I've realized that I should have never even ever picked up a cigarette. And it was probably peer pressure.
Yeah.
And it took me, 5-8 years or so. I think it more like 8 years before I finally quit.
Yeah.
But I've had my own struggles with addiction, with this addiction to nicotine. And so I would tell myself never to give in to peer pressure. And I wish I would have never picked up a cigarette. That's just something that I regret doing. And the other thing I would say is just to push yourself to as far as you can go, because after a certain amount of time you start burning out, and you start getting into other things that interest you, and you lose kind of your focus. And that's one of the hardest things, I think, when kids are going through that transition from being a kid to adulthood, and they're learning how to sort of become an individual, is just try to stay focused and stay on the right path towards success.
Yeah, I couldn't agree more. I mean, I remember being a young, nerdy kid, and whenever anybody told me to do something, you just give in immediately because you want to be cool, right?
Right.
You're one of the cool kids. And definitely there's been moments in my youth, too, where I'm like, I probably shouldn't have made that decision, and it's all a lot of peer pressure, for sure.
Yeah.
I can see those mistakes happening in my mind very clearly. So, yeah.
For sure, yeah. I mean, I've got a 7 and a 9-year-old, and they're just, my 9-year-old, he's already like a teenager, they start early now. And so, I'm trying to train him and get him ready, like, for these things that are going to be happening soon. I mean, with the peer pressure, and letting him know, like, you don't need to, fit in with the wrong kids.
Yeah, 100%.
Yeah.
Well, Dr. Sial, thank you so much for being here today. I really appreciate it. This was a lot of amazing information that, whether you're a doctor, whether you're an attorney, whoever you are out there, if you're somebody who's looking to get, help with pain, this was information that you can take and you can use and you can really apply and kind of see what your options are. So thank you so much for explaining everything in full detail. I really appreciate your time. And, I appreciate you as a resource. So thank you so much.
You're very welcome. Hey, I really appreciate the opportunity to come on here, and I'm excited to be a part of your nasty network.
Hey, thanks, man. I appreciate it. Perfect. Thanks, guys, for chiming in today. We appreciate everyone coming here, and we'll have this up and online. And if anybody has any questions, Dr. Sial, can you please let everybody know how they can contact you, phone, email, and just so that they can reach out if they need anything from you?
Sure, absolutely. So you can reach out. My main office number is 877-786-7246. And that's probably the best way to reach out, just to call the office, and they can basically coordinate if there's anybody who's interested in an appointment.
Okay, fantastic. Okay. Thank you guys for chiming in, and that's going to be it for today.
Nasty.